Hello everyone, and welcome to our Module 4, Part 3. And today's lesson, we are going to talk about anxiety and compulsive disorders. So, this is the last part of our Module 4, and I hope you will learn a lot about anxiety and compulsive disorders. So, without further ado, let's move on to our topic of discussion. So let's now define what is anxiety. So anxiety is a normal human emotion that everyone experiences from time to time. People may feel anxious when facing problems, challenges, changes, or difficult decisions. Dysfunctional responses to anxiety inducing situations. The difference between normal anxiety and an anxiety disorder is that anxiety disorders cause such severe distress that it interferes with someone's ability to lead a normal life. So if you can see, it's normal for us human beings to worry. It's part of our fight or flight response. So this is our natural response to something threatening. If you remember your biopsych or if you study your biopsych, you will learn that the fight or flight system helps the animals flee from predators, especially if they are the prey or if they encountered something that is threatening. So now, anxiety disorders, on the other hand, they are so severe or they are abnormal in a sense that it causes the person extreme distress, and because of too much worry, the person cannot live or cannot do the normal things that he does when he doesn't have that disorder. So it really interferes with someone's ability to lead a normal life. So what then are anxiety disorders? So this is defined by excessive worry, apprehension, or fear about future events, situation, either real or imagined. So anxiety disorders refers to any number of specific disorders including generalized anxiety disorder, phobia, panic disorder, obsessive-compulsive disorder, post-traumatic stress disorder, and social anxiety disorder. So, however, in DSM-5, compulsive disorders, obsessive-compulsive disorders, and traumatic stress disorders are a separate chapter in the DSM-5, but they have very similar symptoms and signs as that of an anxiety disorder. So, what are some specific symptoms that you can feel when you have anxiety disorders? So, these are the common signs and symptoms. So, first, feelings of panic, fear, or uneasiness, uncontrollable and obsessive thoughts, flashbacks to traumatic events, problems sleeping, nightmares, shortness of breath, nausea, muscle tension, dizziness, heart palpitations, dry mouth, cold or sweaty hands. So as you can see, not only that anxiety disorders have psychological manifestations, but it also has physical manifestations through somatic symptoms such as shortness of breath, nausea, being nauseous, muscle tension, dizziness, okay, heart palpitations, dry mouth, cold or sweaty hands. So a person with anxiety disorder may not feel that they are anxious or really anxious, but their physical symptoms are the ones that are manifesting the anxiety. So for example, someone with anxiety disorder got triggered in a meeting, but she doesn't feel any anxiety during that time. But after the meeting, her stomach really cramped. So she did not have any food that she remembers eating that would cause that. She thought that it was really an anxiety attack. So, anxiety can manifest in either physical or psychological manifestations or even both. What is a clinical description of anxiety disorder? So, anxiety disorders symptoms interfere with the most important areas of functioning or cause marked distress. So, if you still remember our 4D, so dysfunction and distress. So, it's really there as a sign of a possible anxiety disorder. So, of course, those symptoms are not caused by a drug or medical condition. So that is part of our exception clauses. And another thing to mark when diagnosing anxiety disorders, it must be persistent for at least 6 months, or for panic disorders, at least 1 month. So fear and anxieties are distinct from symptoms of another anxiety disorder. So when we say fear, these are in response to present threat. So current threat, that's fear. So for example, in phobias, so of course, when you are presented with the thing you fear the most, of course, your fight or flight response will kick in. Anxieties are responses to future events. So this is also known as worry. But anxieties become very distressful if it is for long-term or persistent. The first of our list in anxiety disorders are generalized anxiety disorders. So what is that? So generalized anxiety disorders are characterized by chronic anxiety that is excessive, uncontrollable, and often irrational and disproportionate to the actual object of concern. So people with GAD often characterize it as feeling of free-floating anxiety. This is the term used by Sigmund Freud during his early work. Typically, the anxiety has no definite trigger or starting point. And as soon as the individual resolves one issue, another source of worry arises. People with GAD also tend to catastrophize. So what do we mean by catastrophize? Meaning, they may assume the absolute worst in anxiety-inducing situations. Racing thoughts, inability to concentrate, and inability to focus are characteristics of GAD. So if you remember in our TOP class, the CBT, the Cognitive Behavioral Theory of Beck, so he said that one of the irrational thinking that we people do is catastrophizing. So people with extreme anxiety or with anxiety disorders think the absolute worst that can happen in every situation. So for example, while reviewing the test, since the test causes him stress or is a trigger, the person with GAD will tend to catastrophize that he will not pass or she will not pass the exam, or she may not even able to get that exam or even review properly. So there are racing thoughts, of course, inability to concentrate, and of course, focus. So GAD is a particularly difficult disorder to live with because the individual's anxiety is not tied to a specific situation, event, and they experience little to no relief. So the disorder can contribute to problems with sleep, work, and daily responsibilities, and of course, often impact close relationships. Since people with GAD have no definite trigger or starting point, some of them even lock themselves in their rooms because of fear when they go out. They sometimes feel agoraphobia. Agoraphobia is being in situations where escape might be difficult. So some people are afraid, for example, in very close spaces because they feel agoraphobic. They feel that they cannot escape, for example, in elevators, or for example, in a car, or even, for example, in a mall where there's a lot of people. So sometimes people with generalized anxiety disorder may have agoraphobia. So that's why it's really debilitating. So they cannot experience life outside. So what are now the diagnostic criteria for generalized anxiety disorder? So letter A, excessive anxiety and worry, apprehensive expectation, occurring more days, not for at least 6 months, about a number of events and activities such as work, school, or performance. Okay, so one key thing that you need to remember for generalized anxiety disorder is excessive anxiety and worry. And of course, it must be at least 6 months before you can diagnose. So the second one is, of course, the individual finds it difficult to control the worry. Okay, so it doesn't help if you tell the person with GAD nga, stop worrying. Come on, don't think about it. It will not help. Instead, they would still think about it more on how to stop them thinking about it. So that's why it's really debilitating, and that's why some people really need therapy and help for them to control or manage their anxiety. So letter C, the third one, is of course, the anxiety and worry are associated with 3 or more of the following 6 symptoms. So you just need at least 3 out of 6, with at least some symptoms being present for more days for not more than 6 months. So only one item is required for children. So I think I have discussed the common symptoms like restlessness, being fatigued, difficulty concentrating, irritability, muscle tension, sleep disturbances. Okay, so of course, the letter D, the dysfunctional clause. Letter E is of course the substance clause. And letter F is cannot be better explained by another mental disorder clause. Okay, so as you can see, if you notice, mood disorders also kinda have similar symptoms and signs of anxiety, but the differences in that is that anxiety is more of towards worrying, being keyed up or being worked up. Meanwhile, in mood disorders, in depression, one is feeling down, depressed, okay? And the second one, in bipolar, the manic symptoms are being feeling elated or irritable. Okay, so those are the key differences when you want to differentiate depression from bipolar and anxiety. So I don't know if I could illustrate it. So to illustrate what is the difference between mania, depression, and anxiety, I would like to give this illustration of a roller coaster. So, at the start of the roller coaster, when going up the roller coaster, you feel nervous, you feel keyed up, you feel on edge. So, somehow that's the feeling of anxiety, but abnormal anxiety is persistent, so it lasts a long time. So, imagine having butterflies on your stomach throughout the week. You feel nervous, nauseous. So for example, when you reach the very top, so of course it's a mixture of nervousness and at the same time, sometimes you feel elated, you feel excited because you're already on the top. So that's the example of mania. And then once the roller coasters will go down, right? The thrill, quote unquote thrill of going down, it's somehow like a feeling of mania. The thrill, the being elated, excited, and then once you hit the bottom, so you feel sad, you feel like though the thrill was over. Okay, so you feel sad. So that's example of depression that I can give an illustration. So imagine that being persistent for 2 weeks. You feel that the thrill is not there anymore. You don't feel any pleasure from the roller coaster. So then again, the cycle again begins and then you will go up again, either feeling excited or nervous or keyed up. So that is my illustration of what is the difference between mania in bipolar versus depression and anxiety. So next, panic disorders and panic attacks. So, a panic attack is a sudden period of intense anxiety. If these attacks occur often, they may indicate a panic disorder. So, what then is a panic disorder? So, let's first define a panic. A panic attack is defined as a period of extreme fear or discomfort that develops abruptly and reaches a peak within 10 minutes. Its symptoms include accelerated heart rate, sweating, trembling, choking sensations, hot flashes or chills, dizziness, lightheadedness, fear of losing control or going crazy, and fears of dying. So sometimes panic attacks are expected, occurring in response to specific environmental triggers. Other times these episodes are unexpected and emerge randomly. People with panic disorder experience recurrent and unexpected panic attacks along with at least 1 month of persistent concern about additional panic attacks, worry over the consequences of the attacks, or self-defeating changes in behavior relating to the attacks. So when we say panic attack, of course, this is a brief period of extreme fear or discomfort that usually occurs in a shorter time. So the peak is 10 minutes. So the key differences between panic attack and anxiety attack is that panic attack lasts for a brief period. Okay, so at maximum 10 minutes, 10 to 20 minutes. And there is extreme fear or discomfort during that time. So there are panic attacks are sometimes expected. For example, in environmental triggers such as your fear, or for example, such as being inside a tunnel and you feel agoraphobic. So sometimes people with panic disorder feel agoraphobic. Other times, these episodes are unexpected, such as when the person is already relaxing and then suddenly a panic attack occurs. People with panic disorder experience recurrent and unexpected panic attacks at least 1 month, about concern about additional panic attacks and worrying consequences of the attack or self-repeating changes in behavior relating to the attacks. So, people with panic disorders are concerned about their next panic attack. So, they are so concerned that it would make them worry or suddenly change their lifestyle or behavior in response to avoiding another panic attack. Since panic attacks can occur unexpectedly, they can become a cause of ongoing worry and avoidance. People with panic disorder may become so afraid of having panic attacks that they experience what are now known as anticipatory attacks, essentially panicking about potential panic attacks and entering a cycle of living in fear of fear. So that what makes a panic disorder really debilitating is that a person cannot really enjoy life to the fullest because of worrying that they would get another panic attack, because they are so afraid of that attack that sometimes they anticipate that they will get attacked. Panic disorder is very treatable. However, left untreated, it can significantly reduce the quality of life. People with untreated panic disorder are at an increased risk for specific phobias such as agoraphobia or fear of leaving the house, and they often suffer from one or more additional mental health conditions such as depression and substance abuse. So that's how debilitating a panic disorder is. So just to add, people with anxiety disorders can also have panic attacks, but it becomes a panic disorder if it is persistent and they worry about having another panic attack. Let's see what's the DSM-5 criteria. So, of course, key diagnosis or the key symptom here is recurrent and unexpected panic attacks. So, a panic attack is an abrupt surge of intense fear or more intense discomfort that reach a peak within minutes, and during which time 4 or more following of the symptoms occur. Palpitations, pounding heart or accelerated heart rate, sweating, trembling, shaking, sensations of shortness or breath or smothering, feelings of choking, chest pain or discomfort, nausea or abdominal distress, feeling dizzy, unsteady, lightheaded or faint, chills or heat sensations, paresthesias or numbing or tingling sensations, derealizations or feelings of unreality or depersonalizations or being detached from oneself, fear of losing control or going crazy, and fear of dying. So, of course, there is a note for culture-specific symptoms. And, of course, the letter B, the attack should have been followed by 1 month or more or both of the following: persistent concern or worry about additional panic attacks, and a significant maladaptive change in behavior related to attacks. The person tries to avoid situations in which a possible panic attack might occur. So, of course, the letter C is the substance use clause, and letter D is the another mental disorder clause. So, the next on our list, so after panic disorders, the next on our list is social anxiety disorder, or also known as social phobia. So, social anxiety disorder is marked by intense fear and avoidance of social situations in which one might be negatively judged. So, social anxiety disorder is characterized by extreme and persistent fear or anxiety and avoidance of situations in which the person could potentially be evaluated negatively by others. The heart of the anxiety in social anxiety disorder is the person's concern that they may act in a humiliating or embarrassing way, such as appearing foolish, showing symptoms of anxiety such as blushing, or doing or saying something that might lead to rejection, such as offending others. The kinds of social situations that may cause distress include public speaking, having a conversation, meeting with strangers, eating in restaurants, or using public restrooms. Although many people become anxious in social situations like public speaking, the fear, anxiety, and avoidance experienced in social anxiety disorders are highly distressing and lead to serious impairments in life. Social anxiety disorder, the key point here is that there is fear or anxiety and avoidance of social situations. And they fear that they may be negatively viewed by others. So that is the root of their anxiety. So that's why they try to avoid as much as possible social situations that people will try to negatively view them. So such as public speaking or having a conversation or meeting with strangers or eating in restaurants or public restrooms. So physical symptoms often accompanying social anxiety disorder includes excessive blushing, excessive sweating, trembling, palpitations, and nausea. Stammering may be present along with rapid speech. Panic attacks can also occur under intense fear and discomfort. So that's how debilitating social anxiety disorder is, because it does not help the person. So what is the diagnostic criteria for social anxiety disorder? The letter A, marked fear or anxiety about one or more social situations in which the individual is exposed to possible scrutiny by others. So this includes social interactions like having a conversation, meeting unfamiliar people, or being observed and performing in front of others. So note, in children, the anxiety must occur in peer settings and not just during interactions with adults. So letter B, the individual fears that he or she will act in a way that show anxiety symptoms that will be negatively evaluated. So they really fear negative evaluation by others. And letter C, social situations almost always provoke fear or anxiety. And of course, social situations are avoided or endured with intense fear or anxiety. That's why people with social anxiety disorders that are left untreated, they are unable to develop social skills. They are unable to communicate well with others because they fear to be negatively viewed by others. So of course, the fear and anxiety is out of proportion. The fear and anxiety or avoidance is persistent, lasting at least 6 months, and it causes distress and dysfunction when it comes to their life. Fear and anxiety is, of course, the not the substance use clause, and of course, the letter I, the not other mental disorder clause, and of course, not other medical condition clause. And of course, there's a specifier if the anxiety is during performance only. So this is restricted to speaking or performing in public. So I forgot, I know a comedian who has social anxiety disorder, but his social anxiety disorder is more on when he performs on stage. So that's performance only social anxiety disorder. Now, let's move on to obsessive-compulsive disorders. So this is a separate chapter in the DSM-5. So it includes OCD, body dysmorphic, hoarding, and other disorders. Okay. So obsessive-compulsive disorder is a mental disorder characterized by intrusive thoughts or obsessions that produce uneasiness, apprehension, fear, or worry, and by repetitive behaviors or rituals, or also known as compulsions. And it is aimed at reducing the associated anxiety. People with OCD may have just the obsessions or a combination of obsessions and compulsions. So, key terms: OCD have intrusive thoughts or obsessions. They can't stop thinking about something, and it's intrusive because they cannot concentrate. They cannot do a certain job because of those intrusive thoughts, and they feel uneasiness and apprehension or fear or worry because of that intrusive thoughts. And so, for them to calm down or to reduce that associated anxiety, they try to do rituals or what we call compulsions. And rituals are behaviors. Rituals are observables. Okay? So I hope that's clear. Okay, there are types of OCD. So first, predominantly obsessive thoughts, predominantly compulsive acts, and of course, mixed obsessional thoughts and acts. So to define further what are obsessions, so obsessions are characterized as persistent, unintentional, and unwanted thoughts and urges that are highly intrusive, unpleasant, and distressing. So what are some themes of obsession? So first is prevention of harm to self or others resulting from contamination. So for example, fear of dirt, germs, bodily fluids or feces, and dangerous chemicals, or even COVID. So some have that obsessions. Okay? Others, another theme is the prevention of harm resulting from making a mistake. So for example, a door not being locked will result to thieves coming in. So it's very intrusive. Another is intrusive religious thoughts. Okay? Another is intrusive sexual thoughts. So they have intrusive thoughts of being a pedophile or being a voyeur, something like that. Or they can't just stop thinking about sex. Okay? Intrusive thoughts of violence and aggression. Example, stabbing one's baby. And the need for order or symmetry. So I think the key difference between obsessions and premeditated murder, because there's an intrusive thoughts of violence or aggression, is that in obsessions, it's intrusive. They cannot stop thinking about it. Meanwhile, those who really have an intention to kill, they are set on it, and they can focus on what they can do to achieve that. Meanwhile, with people with OCD, they cannot control it. So compulsions, these are ritualistic behaviors that an individual performs in order to mitigate the anxiety that stems from obsessive thoughts. So one example of compulsion is, of course, behaviors such as repeated and extensive hand washing, cleaning, and or checking. For example, making sure the oven is off, counting things, hoarding, or ordering, or lining up all the pencils in a particular way. They may also include such mental acts such as counting, praying, or reciting something to oneself, as well as nervous withdrawals such as touching a doorknob or opening and closing a door a certain number of times before leaving a room. These compulsions can be alienating and time-consuming, often causing severe emotional, interpersonal, and even financial distress. The ability to relieve their stress is often temporary, and individuals may have a hard time switching from one task to another. The acts of those who have OCD may appear paranoid and potentially psychotic or disconnected from reality. However, OCD sufferers generally recognize their obsessions and compulsions as irrational. Roughly 1/3 to 1/2 of adults with OCD report a childhood onset of the disorder. I think compulsions are behavioral, and people can see that. And it's not only repeated behaviors for you to at least calm yourself down, but it also includes rituals. So like excessive praying or excessive talking to yourself just to calm down. People notice it because the rituals are really time consuming, and this may cause dysfunction and distress not only to the person but also others who are involved. So let's see the epidemiology of OCD. Lifetime prevalence of 2 to 3% amongst general population. And lifetime prevalence of obsessive-compulsive symptoms is estimated to be 8.7%. It's fairly consistent across cultures. Amongst outpatients in psychiatric clinics, they are only in 10%. Gender distributions amongst adults, amongst adolescent boys are more likely to be effective. Onset of symptom around 20 years of age, onset slightly earlier for men. 2/3 have onset symptoms before 25, less than 15% have symptoms originating after the age of 35. And more single people have obsessive-compulsive disorders than married people. So this is the diagnostic criteria. Just to remember that there's a presence of obsessions, compulsions, or both. Characteristic B or criteria B, these obsessions or compulsions are time-consuming. So usually takes more than an hour per day. And of course, it causes distress and dysfunction to the patient. So, of course, letter C, it's not because of a drug. Letter D, it's not because of another mental disorder. So, there is also a specifier for insight. So, those who have good or fair insight, those who have poor insight, and those with absent or delusional beliefs. So, that's why in your MSE, you are going to ask if they are aware of it. So, next is body dysmorphic disorder. So, an individual with body dysmorphic disorder is preoccupied with a perceived flaw in their physical appearance that is either non-existent or barely noticeable to others. These perceived physical defects cause the person to think that they are unattractive, ugly, hideous, or deformed. These preoccupations can focus on any bodily area, but they usually involve the skin, face, or hair. The preoccupation with imagined flaws drives the person to engage in repetitive and ritualistic behavioral mental acts, such as constantly looking in the mirror, trying to hide the offending body part, comparison with others, and in some extreme cases, cosmetic surgery. So, of course, it is severely impairing the quality of life. Bodily dysmorphic disorder can lead to social isolation and involves especially high rates of suicidal ideation. An estimated 2.4% of the adults in the US meet the criteria for body dysmorphic disorder, with slightly higher rates in women than in men. So let's see the diagnostic criteria for body dysmorphic disorder. First, of course, preoccupation with one or more perceived defects or flaws in physical appearance that are not observable or appear slight to others. So, for example, the person is really preoccupied with the way her nose is slanted. It's really slanted, but other people says, no, there's nothing wrong with your nose, okay? Or it's just slight. It's not really a definite flaw. So, but the person is really preoccupied with that. So, another is they have repetitive ritualistic behavior. So, it's somehow like OCD. They have also obsessions and compulsions, but it is directed to the body, to one's body. So, for example, mirror checking, excessive grooming, skin picking. So, for example, a person who thinks that her nose is ugly, really ugly because there's a defect on the nose, might always check the mirror or even cover her nose. Okay? So, also seeking reassurances to others. Or they have mental acts such as comparing her nose to another or to her friend. So, of course, these preoccupations cause significant distress and, of course, dysfunction to the person's life. So, maybe the person cannot concentrate to her studies because she's really preoccupied with the way her nose is looking. Appearance and preoccupation is not better explained with concerns with body fat or weight. Okay, so because if it's concerned about body fat or weight, this is already a different mental disorder or this is already an eating disorder. Specify if there is with muscle dysphoria. So this is typical or this is usually diagnosed in men. So, the person is preoccupied with the idea that his or her body build is too small or insufficiently muscular. So this specifier is used even if the individual is preoccupied with other body areas, which is often the case. There is also, we will also indicate the insight of the person. So with their disorder beliefs. Okay, so with good fair insight, poor insight, or absent or delusional beliefs. I think that's the end of our lesson for this week. So I really hope that you really learned a lot about, especially anxiety disorder. So oftentimes, these are also one of the common disorders that really needs attention towards mental health practitioners. So most of the time, it is also comorbid with substance use disorder or with mood disorder. So as you can see, I hope in our week 4, you have already identified what are the similarities and differences of the substance use disorders, of the depressive disorders or mood disorders, and of course, anxiety and obsessive compulsive disorders. So, next week, we will talk about trauma and dissociative disorders and personality disorders. So, this trio, these are also related to each other. So they can also be comorbid or a precursor to each other. So as you can see in the flow of our lesson, it's really connected. Our lessons are really connected in such a way that we learn about first one disorder and then we realize that, oh, it's connected to the next disorder and then the next disorder. It's like we are connecting it by comorbidity and at the same time the course or progression of a certain disorder. So I hope to see you on Thursday and Friday for our first case conference, and I hope the groups are prepared for their cases to be presented. So see you on our discussion, live discussion, and goodbye.